Hey everyone, and welcome to The Explainer. Today, we're tackling a true clinical puzzle, Behçet Syndrome. First described by Turkish dermatologist Hulusi Behçet, it's a complex, multi-system disorder that, honestly, just completely ignores the usual rules of rheumatology. Let's get right into it. Right off the bat, the core diagnostic dilemma here is super fascinating. Imagine this. How exactly do you diagnose a severe systemic vasculitis when there are absolutely no specific lab tests? Unlike lupus or rheumatoid arthritis, Behçet's has zero defining autoantibodies. There's no simple blood test to give you a definitive yes. Because of that, your clinical observation and mapping out a patient's symptoms over time are absolutely crucial. So here is our roadmap from mystery to mastery. We'll cover the enigma, pathophysiology, clinical clues, ocular and vascular complications, the ISG criteria, and pathargy, and we'll wrap up with therapeutics. All right, Section 1, the enigma. Like we just mentioned, because we lack a definitive blood test, diagnosis relies entirely on recognizing clinical patterns. As a clinician, you effectively have to act like a detective. You're piecing together a puzzle, meticulously tracking a patient's symptoms, sometimes over months or even years, just to finally make the call.
Moving on to Section 2, Pathophysiology.
Okay, let's dive right into the cellular level. The core mechanism driving Behçet syndrome is a condition called leukocytoclastic venulitis. Basically, this means there is severe inflammation and actual damage happening directly within the walls of the blood vessels. This underlying pathologic process is exactly what eventually leads to tissue ischemia and that wide array of symptoms we see in these patients. Now, what makes Behçet syndrome so incredibly unpredictable is its vascular tropism. Most forms of vasculitis are categorized by the specific size of the vessels they attack, right? Small, medium, or large. Well, Behçet's, it just doesn't discriminate. It can involve blood vessels of literally any size, whether venous or arterial, and in any organ of the body. This is exactly why the disease can present in such wildly diverse ways, anywhere from a tiny skin lesion all the way up to a massive arterial aneurysm. Which brings us to Section 3, clinical clues. Let's walk through the physical hallmarks of the disease. These are most commonly associated with mucocutaneous tissues. First up, we have recurrent oral ulcers. These show up in nearly 100% of patients, and they're usually the very first manifestation of the disease. They look a lot like ordinary canker sores, and you'll typically see multiple of them at once. Next, we look for genital ulcers, most commonly on the scrotum or labia. These are highly specific to Behçet's. They are larger, deeper, take way longer to heal, and crucially, they tend to form permanent scars. Patients also frequently develop acneiform or papulopustular lesions. These are visually indistinguishable from standard acne, but they can pop up in really unusual places, like the lower extremities. Finally, we see nodular lesions like erythema nodosum. Those are tender, red bumps caused by paniculitis, and superficial thrombophlebitis. If you see inflamed superficial veins, that should immediately trigger a workup for deeper vascular involvement. Next up, Section 4, ocular and vascular complications. Eye involvement is serious business here. It's seen in about half of all patients, but that number actually jumps to up to 70% in males. It most commonly presents as a bilateral panuveitis. Male gender, posterior eye involvement, and frequent attacks, meaning more than 3 per year, are all really poor prognostic factors. If it's not treated aggressively, this retinal vasculitis and uveitis can quickly lead to permanent blindness. Now, this intense inflammation can build into a very specific and frankly surprising manifestation called a hypopyon. This is a visible pooling of inflammatory cells, basically pus, right there in the anterior chamber of the eye. While you only see it in about 10% of patients who have eye disease, when you do see it, it is incredibly specific to Behçet syndrome. Beyond the eyes, we're looking at grave, life-threatening complications. Because Behçet's attacks vessels of any size, up to 40% of patients experience relapsing intensive thrombosis, meaning blood clots in both deep and superficial veins. Even more terrifying are pulmonary artery aneurysms, which carry a steep 20 to 25% 5-year mortality rate. Neurologically, about 5% of patients suffer central nervous system involvement. This usually strikes the parenchymal brain tissue, specifically at the telencephalic, diencephalic junction and brainstem. This can cause severe headaches, cranial nerve palsies, and hemiparesis. And, if that wasn't complex enough, Behçet's is an absolute master of mimicry, particularly down in the gastrointestinal tract. Intestinal involvement can look exactly like Crohn's disease. However, Behçet's ulcers are typically single or few in number, round, deep, and highly prone to perforate. They're usually confined to the ileocecal area. Honestly, without seeing other extraintestinal clues like those scarring genital ulcers or eye lesions we talked about, it is incredibly difficult to distinguish Behçet's from Crohn's based on endoscopy alone.
Section 5. ISG criteria and pathergy. Let's look at how we actually classify this.
So, the International Study Group, or ISG criteria, work kind of like a mathematical formula, offering about 95% sensitivity. To make the diagnosis, a clinician must observe the mandatory criterion: recurrent oral ulcers occurring at least 3 times in a 12-month period. But that alone isn't enough. You have to combine that mandatory symptom with exactly 2 of the 4 secondary criteria: recurrent genital ulcers, skin lesions, eye lesions, or a positive pathergy test.
Now, you might be wondering, what exactly is a pathergy test? Well, it's a fascinating quirk of Behçet's. It basically tests for a nonspecific hyperreactivity of the skin to physical trauma. A clinician simply inserts a sterile 20-gauge needle into the dermis of the forearm, and then they wait 24 to 48 hours. In a patient with Behçet's, this minor little prick causes an intense, localized inflammatory reaction, resulting in a visible popule or pustule.
Finally, Section 6. Therapeutic guidelines.
The overarching management philosophy for Behçet syndrome is really about bridging the patient safely through the worst of the disease. The primary goal is to prevent long-term, irreversible tissue damage, especially in those vulnerable areas like the eyes and blood vessels. Interestingly, the disease often runs a natural course of diminishing symptoms over time. Because it tends to abate, clinicians will often attempt to taper or even completely stop immunosuppressive medications 2 to 3 years after a patient's symptoms have significantly improved. When active treatment is needed, it is highly targeted based on which organ system is currently under attack. For mucocutaneous symptoms, we rely on topical glucocorticoids, colchicine, and apremilast. For ocular or severe systemic involvement, you need aggressive immunosuppression. Azathioprine is generally the preferred agent here, often combined with TNF-alpha inhibitors like infliximab or adalimumab. And for those severe, life-threatening vascular complications we talked about, powerful agents like cyclophosphamide are deployed to halt the intensive thrombosis and aneurysmal damage.
Before we wrap up, I want to highlight this quote from the medical literature. It really shows how our understanding of Behçet's is still evolving. We're learning that the disease presents in distinct clinical phenotypes, or clusters. For instance, patients presenting with acneiform lesions often cluster with arthritis and enthesitis. This suggests that what we collectively call Behçet syndrome might actually be driven by several different underlying pathogenic mechanisms.
Which brings us to our final thought. As we map out these distinct disease clusters within the Behçet's enigma, will the future hold even more targeted, highly individualized therapies? It's a profound question, and one that highlights the rapidly evolving landscape of precision medicine and rheumatology. Thanks so much for joining me for this explainer. Keep looking for those clinical clues and never stop questioning the mysteries of the human immune system.